Hi, everyone. Good afternoon. Welcome to the February 2025 PQA Quality Forum Webinar. I am Tammy Malm, and I am the Director of Education at PQA. I will be your host for today's webinar, and our topic today is rare disease, addressing inequities in care and improving quality. Before we get started, I have a few housekeeping items. First, please submit your questions during the presentation using the Q&A feature that's at the bottom of your screen. We'll answer as many questions as we have time for during the discussion portion of the webinar at the end. I will be keeping very close track of all of them and putting them into my document. Also, the webinar recording and slide deck will be available to PQA members within the week following the presentation, so around this time next week, no later than this time next week. It will be in the Member Resources Library section on the PQA website, and we will post the recording onto PQA's YouTube channel. Last, I would like to encourage all attendees to complete the very quick 1-minute survey that will appear at the end of the webinar. This helps us continue to create good educational sessions, good webinars, and answer the questions that you have or tackle the content that you want to see. So it is now my pleasure to introduce you to today's presenters. We are joined by Jocelyn Cooper, who is a program manager for the Rare Disease Diversity Coalition at the Black Women's Health Imperative. Welcome, Jocelyn. Thank you for being here. We are also joined by Richard Schmitz, the Chief Engagement Officer at PQA, and I am going to hand the mic over to Richard.
All right, thank you. Thank you everyone for joining us today. I want to start by just providing some kind of basic key facts about rare disease and medication use to get us started. Rare disease is generally, defined in the United States as a condition that affects fewer than 200,000 people. And so far, more than 7,000 rare diseases have been identified. Some estimates have that as high as 10,000. And collectively, they affect more than 30 million Americans. The economic burden of these diseases is enormous. It's more than $1 trillion each year. Despite the prevalence of rare diseases, only about 5% of them have treatments that are approved by the FDA. However, that situation is beginning to evolve. Over the last 10 years, we've seen a significant increase in the approval of orphan-designated rare disease medications by the FDA. And you can see on the chart here that today they account for roughly half of all newly approved drugs. And there are some estimates that as many as 10 rare disease drugs may be approved in this calendar year. So given this increased focus and availability of rare disease medications, PQA wanted to take an opportunity to kind of shine a light on quality issues around rare disease medication use. Last November, we convened our members, experts, and individuals in the rare disease community for a PQA Convenes event that's really designed to highlight the importance of quality in rare disease, discuss barriers to access of medications, and then the care that surrounds a rare disease medication prescription, which is far more complex and involved than a typical prescription, and also build a foundation for consensus on quality issues. In our work to create and implement this event, we saw a lot of conversation among our stakeholders about what they think constitutes quality in this space. But a lot of that work is kind of happening in isolation. So we wanted to bring different stakeholders together so that they could share their perspectives with each other and together. So we had 4 panels, one of patients, caregivers, and patient advocates, another specialty pharmacies and providers, third on from the biopharmaceutical industry perspective, and then finally, public and private payers. Each of these has kind of a key role to play in the medication use process. So our panels kind of had 20 individuals with lived experience or expertise on the issues. Across the panels, a number of key insights emerged. One, particularly from the patient perspective, was the importance of care coordination. Patients have to organize and manage an enormous number of providers to deal with the complex needs that are characterized by a rare disease condition. So care coordination stood out as a key area for improving quality. And from the specialty pharmacy perspective, the importance of having access to the patient health records to enable them to be supportive in the process and coordinating care being able to manage needed services, copay assistance, approvals, all the things that specialty pharmacies can aid on to help patients navigate these complex treatments. Additionally, there was the need for ongoing collection of rich data to capture the full patient experience. One of the observations that was made is that kind of a snapshot of a rare disease patient doesn't tell you a lot, given the enormous change that can happen in a disease state in the course of a patient's treatment over an extended time on a rare disease medication. And for us to understand the true value and quality of any medication, we need to have that fuller view of what the experience looks like. And then finally, just the importance of care management. This is the idea of the importance of having intentional services to support rare disease patients and their complex needs throughout the process, so that if they are prescribed a medication, that they have the appropriate support and services to be able to stay on a medication and have the best outcome possible. Across all of our conversations, access was a key factor, and we concluded the event with kind of a informal survey of what we thought our attendees, about 100 of our stakeholders, thought were the primary or key barriers that could prevent a patient from accessing rare disease care. And many of our attendees' priorities focused around kind of the cost and logistics complexities of accessing care and medications. And I think it's important to kind of compare that to the perspectives of patients and caregivers. And on the right, you'll see a snippet from a survey you're going to hear about more in detail shortly. But the patient and caregiver perspectives often focused more on the disease burden and also kind of the challenges of navigating the system. And we did hear a lot from our patients about the difficulty of getting an accurate diagnosis, of not being able to get their symptoms and concerns effectively heard in a timely way. So I think, this is just an opportunity to think about as we approach opportunities to improve care in medication use for rare disease, to kind of keep the patient perspective and needs forefront in that. There are a lot more insights that are available in the report that we produced following this event, and a link to that report has been dropped in the chat window here. We're hoping that this report will be kind of, a good contribution to the national conversation on rare disease, and illuminate areas where key stakeholders can work together on common ground and common goals to improve quality for patients. Lastly, I want to conclude by thanking Pfizer, Novo Nordisk, and Jazz Pharmaceuticals. Their support for this event allowed us to bring people together in person, but also have an enduring report to kind of carry the conversation on after that event last fall. So we thank them for their support, as well as all of our speakers and members who helped provide insights to build the report. So with that, I'd like to now introduce Jocelyn Cooper, who's going to provide a deeper dive on inequities in the rare disease community.
Thanks so much, Richard. And thank you, everyone, for being here today. So excited to move forward. I want to extend a special thanks to today's host, which is PQA, for just allowing us to come together. We always welcome the opportunity to collaborate with great organizations that are doing things to help move this cause forward. And we know that this webinar series is doing just that. So we're excited to be here and share more with you. I first want to just offer you a little bit of insight about the organization that I work with and represent. So I work for the Rare Disease Diversity Coalition, which is a signature program of the Black Women's Health Imperative. And so we were launched in May of 2020, yes, in the middle of the pandemic, just recognizing that there are extraordinary challenges faced by underserved populations and communities within rare disease. Black Women's Health Imperative has been around for 41 years, and it's always been centered around the empowerment and uplifting and advancement of health of Black women. But there became a greater need where we saw, beyond just Black women, other BIPOC or marginalized audiences needed additional support as it related to all things rare disease. And so our esteemed leaders decided to put together a coalition as a signature program that would help address this with industry leaders. And so our current model has over 95 organizations that are members, but altogether collectively, we have about 200 members or individuals that represent our coalition for RDDC. And so it is comprised of patients and caregivers, but we are also made up of experts, industry leaders, whether biotech or pharma, and we have community advocacy organizations as well as patient advocacy groups that participate. And it's all to make sure that we can work together to develop evidence-based solutions that can help move the cause of all things rare disease forward, but to make sure that that rare audience of collective individuals that make up all things diverse are not forgotten about. And so that's where we stand as it relates to the Black Women's Health Imperative and the creation of RDDC. So today, what we're going to be highlighting, as Richard remembered, is really focusing on one of our most recent projects that we're so proud of. You know, understanding that healthcare systems and the landscape are not basically set up to timely diagnose and care for individuals that are living with rare disease. We thought that it was super important for us to focus on what can we do to highlight and get true insight onto what these gaps and barriers look like for these individuals. And so we partnered up with NORD, who is a leader in the rare disease space, the National Organization for Rare Disorders. And we decided that one of our 3 working groups, as you see here, it was the patient provider caregiver team and group that decided to come together and put together a survey and make sure that we collaborated with NORD throughout the entire process. We wanted to make sure that for us, we were putting things in perspective that would give us a more holistic view of what the true inequities and barriers looks like. And so for us, the objectives as a whole, you know, our ultimate goals for the survey were centered around making sure that we were listening to and learning from these underrepresented communities, right? Beyond just gathering data, we wanted to make sure that we had both a quantitative and a qualitative perspective of what some glimpses into their experience were like. And so that means that we had to be very strategic in how we polished and refined and drafted and crafted and curated the questions that were going to be a part of this survey. And so for us, it was ultimately just about making sure that whether it was the diagnostic journey, care, or it was centered around support services as well, we wanted to make sure that we had more deeper, like more profound comprehension of what the true gaps and barriers were. And so that's what we worked with key members of our PPCJ working group, as well as NORD. We collaborated very deeply and collectively together on to make sure that we had these things in mind as we were moving forward with crafting everything. So to give you more insight on how we recruited, because people often ask us, how in the world did you all get 2,800 respondents on this? And it was very grassroots, if we're honest. It was social media, you know, promotion as well as some paid ads. But in the big scheme of things, we depended very heavily on the strength of our network. So we're so grateful for our organization and our partners through the RDDC. That was really what gave us the weight and strength to get this data out between February and June of 2023, so that we can make sure in both English and Spanish, we were working with NORD to promote this collectively and that we were getting the data out to the right individuals. So individuals tapped into their advocacy groups, you know, their particular networks, just to make sure that the patients and caregivers that needed to give insight into this data and information we were trying to receive were actually heard and that their voices were going to be elevated with this. And so it was from February to June of 2023 that this particular survey was disseminated in the community. And we pretty much, as you see from that map, reached quite a few states throughout the entire United States. We even reached Puerto Rico as one of our locations that provided insight for respondents. So in the end, the great news is that at the end of that, we were able to collect data from over 2,800 individuals that responded. And as you see, what we were so excited to learn and get even more insight on is that 22% of the individuals that responded were caregivers. So we knew immediately, oh, that's going to provide us a unique advantage, right, in this particular survey to just give us deeper insight when we take a look into the holistic journey of this, right? It's not just the person or individual living with rare disease, but it is also their entire village. And so we were excited to see that we had a significant sample size of individuals as it relates to the data, the survey data centered around rare disease. So just for clarity, again, when you think about diversity, historically, one of the things that we utilized was the White House definition for diversity. But as we know, things are shifting quite a bit. And so for us, what that means is we want to look at things from a historically marginalized perspective as well as medically underrepresented. So you'll hear me use those terminologies throughout this presentation as well. And so what you see here on the slide is centered around those underrepresented, medically underrepresented respondents that took place in our survey. And so you see BIPOC represented, Hispanic ethnicity, the LGBTQ plus audience, as well as household income below the poverty level, and also rural residents. For us at RDDC, when we talk about that holistic component centered around what diversity means and what medically underrepresented means, this is what we're talking about. All of these audiences from a rare disease space perspective tend to not be as elevated or highlighted when we talk about the rare within rare. And so this is a diverse audience within itself that highlights some key respondents that provided their unique nuances and experiences centered around the inequities and barriers that they face. Now, we definitely highlight that they might be the same or look very similar to other audiences, but we know historically that there are some other elements or components that might impact that as well. So just for a little bit more clarity, BIPOC represents Black, Indigenous, or people of color. The Hispanic ethnicity is individuals that self-identify through this survey as Hispanic, Latinx, or Latin. It just depends on the individual. LGBTQ plus, so that naturally represents anyone that identifies as gay, lesbian, bisexual, trans, non-binary, or self-reported of another LGBTQ plus status. The federal poverty level. So this one is huge because often when individuals think of a diverse population, they don't think about individuals that live in a rural or a rural community or individuals that deal with a certain level of poverty. And so for us, it's determining that based on the reported income of that household or individual, it's the 2023 declaration of what the federal poverty level was. And then the rural resident component, we know because we are healthcare professionals and advocates that one of the greatest things that we all challenge with, no matter what spectrum of healthcare you work in, is centered around individuals that live in rural communities not having access to certain resources, whether it be diagnostic care or treatment as someone that lives in a more urban or metropolitan area. And so they are definitely kind of an outlier when you think about how we formulate the healthcare system, the landscape as a whole. And so for a rare disease perspective, it might be even beyond primary care services, a greater challenge for them, individuals that live in rural communities. All right. So just want to take a moment here to highlight some of our general results and leave those on the screen for your viewing. Like one of the 3 key things that you see that we have highlighted is centered around you were overwhelmed from managing your life, care or caregiving responsibilities. And so as you see what Richard highlighted earlier, this is right in alignment with that. We see this very much in tune with the journey and life of an individual living with rare disease or individuals that are helping provide care for them. So 50% of our results really brought that to the surface, letting people know that, hey, that combined with my feelings of stress, anxiousness, and feeling hopeless at times, 45%, 50%, those are very high elevated numbers. And so we wanted to make sure that, it wasn't just necessarily the narratives that were shared in passing, right? As we encountered these resilient individuals in the community, we wanted to make sure that the data was showing alignment with that. The other piece that I want to highlight here as well is something so key to take a look at is centered around you were experiencing housing instability or food insecurity or just worried about basic needs. So one of the key things that comes up all the time, it's even something that's been highlighted recently, once again, with our patient caregiver advocacy group at RDDC, is that the everyday psychosocial needs make a significant difference in the journey for everyone. And sometimes we're not always thinking about that as we think about providing assistance or support for individuals, because we're just there to design, hey, let's get them their care. They're here for this particular reason, condition, etc. Let's address that. But it's a holistic standpoint. I had shared with Richard and the PQA team before, like some of my background is centered around working in HIV for more than 5 years. And one of the key things that was always top of conversation, much like rare disease, is we really have to holistically address the needs of these individuals, because if they are concerned about how their lights are going to be paid, how their family is going to get food, et cetera, then them taking their medication or embracing any possibilities of treatment or research and clinical trials, all of that is off the table if the everyday basic needs aren't met. And so that's definitely something to consider very heavily. While it seems like a lower number, just at 17%, it still is a significant factor to consider when you think about the already challenged audiences of individuals that we highlighted earlier. And the last one that you see highlighted here is you were worried about being able to fill out all of the forms or understanding what you were supposed to do. So this is not even necessarily always about something centered around education, right? Someone's education level. It's really a place to uplift. A lot of us, I'm sure, here are public health practitioners. And so we know all about our training and background in health literacy, because health literacy is so different from education, right? Individuals are often intimidated by healthcare providers, and we're not just talking about the doctors. It can be the entire care team. It could be the entire experience of preparing to go to the office because you're not sure what news you'll get today. And so individuals in approaching that may have elevated levels of anxiety, and that may be intimidating for them as they prepare to, what forms am I going to have to fill out today? What questions am I going to have to answer today? And making sure that they have a true understanding of what they're supposed to do and how they're supposed to respond. When you look at marginalized audiences as a whole, from a healthcare perspective, a lot of times individuals tend to think of their doctors or providers as right underneath something faith-based, right? Whatever their faith-based practice is, they may say like, oh, in a very similar way or divine way, I don't question my provider. Whatever my doctor or pharmacist, et cetera, says is what goes. I should just do that. And so it's really up to us as healthcare professionals to make sure that for particular individuals, we ask them their viewpoints on things so that we can make sure that we're getting them information in a very palatable and digestible way to ensure that they understand what we're asking them about. And so feel free to drop any questions that you all might have in the Q&A as we continue to move forward with this presentation. So for survey results, we really want to highlight this piece here centered around financial barriers, especially as it relates to prescription medications. So what we asked in our survey in the questionnaire, it was centered around a patient's inability to afford their meds or any treatment within the last 12 months, so in a one calendar year. And so as you see, we have underrepresented respondents, which highlights our historically marginalized communities or our medically underrepresented populations, and then represented reflects individuals in the majority. And so what you see here is that for prescription medications, there was definitely a delta or a variance between individuals that are underrepresented versus represented that had greater challenges being able to afford their prescription medications. And in that same regard, as we just highlighted before, the medically necessary food and supplements. So we know, based on what Richard highlighted earlier and the landscape of the rare disease space at all, only about 5% of these conditions have an FDA approved treatment. So a lot of individuals are depending on things like supplemental or homeopathic or holistic support, and that has a cost as well. And so whether it's the medically necessary food that they're utilizing or supplements, individuals still found that between these diverse audiences, that there was a greater variance of individuals that were having challenges being able to afford their medication or whatever their treatment was consistently. One of the other things that was highlighted, and this is a reflection of what was shared earlier in alignment with what Richard shared earlier, which was to see a regular doctor or general healthcare provider. So whether this was the copay or any other specialty services that may have been associated with it, they're kind of close to one another. As we know, primary care visits are typically slightly lower in cost rather than a specialty care visit, but you still see here that there was a greater variance and higher delta for individuals that are underrepresented. So it's literally double what we see for the represented or majority respondents. And then for follow-up care. So follow-up care visits, we know, are an essential part of healthcare as a whole, but we definitely know that it could create additional barriers or challenges for individuals. And so there is that 10% that we wanted to highlight it versus the 6% for represented respondents that we see that has a higher number when it relates to the medications, the regular doctor visits, and also the follow-up care. So the next few charts just kind of give like a high-level overview of the breakdown of those particular diverse audiences that we showed you earlier and went over. So this is just like a general understanding from a rare disease warrior perspective, like individuals that couldn't afford the cost of those visits. As you see, not underserved or the represented communities, the numbers are significantly lower. But in every diverse audience, rural, poverty, LGBTQ+, Hispanic, and BIPOC, the variances are greater, the numbers are higher. And so what you'll notice throughout the duration of this presentation is that for every small chart, and mind you, this is only an excerpt of a few of the things that we highlighted, every aspect of it is the LGBTQ+ audiences, you're going to see that those numbers are significantly higher in every area. All right. And so the next one is centered around the experiencing housing instability, food insecurity, or just being worried about basic needs. And so as you see here, the greatest challenges are centered around individuals that are seen living below the federal poverty level. It's also individuals in rural communities as well as the LGBTQ audiences. Hispanic and BIPOC are noted as well. But as you see for this particular one, poverty shows the greater need. So the next couple of slides highlight some key things centered around caregiver highlights. And we asked them a series of questions that centered around their experiences naturally as a caregiver. And so the 4 that we want to pull out to highlight here are centered around, since I have been a caregiver, my financial situation has decreased. And so as you see, again, for those underrepresented respondents, that number is 69%, but we do see that it does show 56% for majority respondents. But 69% of individuals said, hey, since I got my child or my partner or my family member or loved one received their diagnosis, the landscape of our financial situation in our home has changed, and that we know is often because an individual may have to either decrease or stop their current employment situation in order to provide care for the individual. So that's a huge one. The next one is big too, and often something that individuals aren't necessarily thinking about that's top of mind. But my health is affected by the care situation. And so one of the key components that we're actively working on and have been talking about, and it's one of our recommendations in the NORD report, is addressing the mental health component of both the person living with rare disease, but also the caregivers, because their physical as well as their mental health can often be impacted by everything that's happening and unfolding. And so as you see, when you look at those underrepresented respondents, that there is a significant delta there when you talk about their health, whether physical or mental, being impacted by their caregiver situation. The next one highlights the care takes a lot of my own strength. And in that same regard, that's highlighted there, showing, 83% respondents say that it really does take a lot of their own strength to serve as a caregiver for individuals. And the last one that we want to really highlight that talks about, I'm worried about my future because of the care that I give. So naturally, individuals give feedback about a number of different things, saying, like, to some degree, in the qualitative points, there were periods where people did highlight, like, basically caregiving has become a large majority of my life. And so they're worried about their future, because how does this impact every single thing that happens in our family, in our household, in my personal future? And so you see that that number is significantly greater for underrepresented respondents at 62%, rather than the represented respondents for these particular caregiver highlights. So in terms of calling out those particular responses, again, we wanted to highlight the different audiences so you can get a greater glimpse of why it's so important sometimes that we do highlight this rare within rare, so that we can see what these particularly historically medically underrepresented audiences look like. And so as you see here, as I highlighted before, the LGBTQ plus audiences for both of these, feeling stressed, anxious, drained, or hopeless, feeling overwhelmed managing life or your caregiving responsibilities, they are the highest number in this particular one. The next one centers around poverty. And then we also see that there's kind of a significant balance, but still always more of an increase between BIPOC, Hispanic, and rural. So either way, we definitely notice that by our data and by our survey and respondents that these unique audiences are always showing a greater levels of stress, anxiety, or feeling drained, or having greater challenges, feeling overwhelmed managing life as it relates to their caregiver responsibilities. So I just want to highlight, there are quite a few, and I've mentioned some of them in the other parts of the presentation, but in general, I want to highlight two key things that make a significant difference. That's highlighted in our report. And so these particular findings really center around the diagnostic journey. So in addition to the quantitative data that we received, we also had some open-ended questions that gave feedback and provided some qualitative data to partner with that. And in those responses, we just found that for so many people, yes, there's challenges once they receive a diagnosis, and yes, there's challenges in terms of needing additional support on the back end once everything moves forward. But the greatest insight that people continue to share is that the delays in diagnosis and the diagnostic journey being so challenging is one of the most significant things. And so improving access to genetic testing is really, really one of the key things that we're, trying to continue to build strategic partnerships and relationships on to work for, especially with these particular audiences. As you see from our research here, genetic testing was not even offered to 85% of the respondents. And that within itself, naturally, those types of things are often the barriers or challenges that contribute to the fact that there's a 5 to 6 year time frame on average in which individuals take to get diagnosed. And so we know that sometimes providers may choose not to move forward with that because it's cost prohibitive. But in the big scheme of things, it's very interesting and something we all have to pay attention to look at the fact that 85% of these individuals were never even offered the option, especially when, as the slide calls out, 72% of rare diseases are genetic in origin. And so that's something that we have to look at, especially when considering everything. And the next one is centered around some key components or aspects of what you all do, right? When you talk about the pharmaceutical connection and the mere fact that medication sometimes drives a significant factor in the treatment of individuals living with rare disease. That's also a part or component that might tie into clinical research and trials as well. But navigating the health insurance landscape is really a huge barrier or challenge for most people living with rare disease. And the truth of the matter is, as you see from our survey, 93% of respondents had some form of healthcare insurance, whether it was commercial, Medicaid, or Medicare, they had coverage, but still had similar barriers. So whether it was being able to afford their copay or not having enough additional or supplemental support with patient assistance programs, it proved to be, like quite the challenge. And so the prior authorization piece, I know Richard will probably touch point on that earlier, on that later, like the key piece of waiting on prior authorizations, trying to get copays taken care of, waiting on additional feedback or insight from patient assistance programs or foundation programs. All of those things create barriers or challenges for all patients, all rare disease patients, but it often is higher in general for individuals that qualify as underrepresented or historically marginalized. So as you see, our data prove that the proportion of denials within itself tend to be higher for individuals within underrepresented communities. So for medication access solutions, one of the things that we've talked about within our coalition, our working group, and just with our patients and caregivers as a whole, right? Getting insight from them on how does this work. Now, one of the key things that we do at the RDDC is we have an entire working group dedicated towards diversity in research and clinical trials. And so increasing that is definitely something that we are working with our partners to say, how can we do better about including patients within these different socioeconomic, racial, and diverse backgrounds to improve equity overall for treatment outcomes. And the reason why is because often the feedback from patients has been, hey, I don't feel comfortable being in this setting. I don't know or have relationship with these individuals. I'm not sure about staying in it because I don't like the way people are talking to me. I don't feel comfortable. They feel a sense of condescension. So it's really about not just getting individuals enrolled, but also getting individuals connected so there isn't a high level of attrition. Okay. Naturally, we all know that depending on what state you're in or what area you're in, that expanding insurance coverage is ultimately going to be like a key piece of it. So we do have a policy arm at RDDC where our policy manager, which is an attorney, advocates and works for, like many organizations, various, policy changes that really cover orphan drugs, genetic testing, and other specialty medications or treatment that are needed, because we know that this is the thing ultimately that will make a huge difference in making sure that individuals get diagnosed more timely and also get the appropriate treatment that they need. Improve provider training. And I'll even update this to say we have shifted some of our language in this area. It's not just providers, it's the entire care team. So one of the things that we try to do at RDDC is look at the care team as holistic, because we know that if you've ever visited an audience where individuals have any type of like audience or office where individuals go in and have wraparound service models where I see the provider, I see the receptionist and the check-in desk, but but then I see the medical assistant, I see the lab tech, I see the social workers. Often what you find is individuals are getting different information throughout that entire medical visit. It's very interesting. And so we have to just look at it beyond just the provider. We have to look at, let's train the entire care team as it relates to not just being culturally competent, but also culturally safe. This requires us to have a lot of conversations with individuals about their insights and what their viewpoint is on medication. Some of this involves their history, their ethnic background. It could just even be an understanding of the medical system as a whole. And I'll share a quick anecdote that might provide some insight into that. That when I was working at the HIV program, one of the things that we did was I speak Spanish as well. And so one of the things that I did was connect with a young lady that was mostly Spanish speaking, but she actually was from an indigenous tribe in Guatemala. So she spoke very little Spanish. But in short, when we got ready to connect her to treatment, she was actually, excited just about getting back healthy because she didn't know what was going on after her diagnosis, because they did not have in her village, they did not have traditional medicine as we see it here in America. Their medical practices were different. And so when she received the medication, while excited about getting well, she immediately turned away from the pill because of the color of it. And she began to explain to me that in her culture, that medication, that color represents bad luck, and so she would not be permitted to change it. So it was then me and her provider working together to make sure that we didn't just get her the best medication for her, but we also had to have these other considerations in mind to ensure that she would take it timely. So that seems like some people would be like, oh, that's an extreme situation or case, but it seems like something small. But in truth, when you work with a number of different ethnic and cultural backgrounds, we have to always ask questions. It always requires us to have conversations. So it could be something huge or something small, but ultimately it's not just about being competent. It's really just about being cultural humility more than anything, and then making sure that we're acting in a way that could be considered like culturally safe for individuals. And then, of course, naturally, third is everyone's favorite bullet, I'm sure, PAP programs, just making sure that those are strengthened and that we're working with individuals, expanding financial assistance and community-based medication programs. So, this of course, we know we have programs like 340B, different foundation programs and things of that nature, but sometimes I think what we often will do is work to just let's go ahead and try to see what we could get covered with one program altogether. But there may have to be a greater synergy in terms of employing multiple financial assistance programs, where permitted and allowed, because we know sometimes that's not the case, but employing more than one program to work together so that we can ensure that patients get their medication more timely and that they get the assistance that they need. All right, so that's all that I have. I hope that provided some great insight into our inequities report, and the team is going to make sure that they'll drop it in the chat for you. I also have my email address in there as well. So we have a great rare disease toolkit that you and your organization can use, as February is, for lack of a better term, Rare Disease Month. And so the toolkit as well as the inequities report is provided in that link. Thank you all so much.
That's fantastic. Thank you, Jocelyn. And thanks for sharing all the important work of the RDDC. For the participants, please submit your questions using the Q&A feature at the bottom of your screen. We will get to as many questions as we can, and I am keeping track of them. Okay, Jocelyn, given your background in HIV care, which of these barriers stands out to you as the most relevant for medication access?
That's a really great question. And by barriers, I guess it's always going to be the financial barriers for sure. But I think one of the greatest things is making sure that we're working with our audiences to ensure that those psychosocial needs are met. Because I think when we think of medication access, we can't just think about their ability to get it, pick up the prescription, and move forward with it. We also have to partner that with, are they actually going to take it? Are
Right.
they going to take it when they get it home? Are they going to take it on time every day? Those are some of the key things and measures that we have to consider. And so that's why highlighting that holistic component of, are those psychosocial everyday needs being met, to make sure that medication access is complete and not just their ability to go pick up a prescription medication. I hope that makes sense.
Yes, looking at the entire medication access cycle. Yes, we get it. Additionally, Jocelyn, the RDDC NORD report, am I saying that right? RDDC NORD report highlighted racial disparities in rare disease diagnosis and in care. What are some changes that you think could help address these inequities?
Yeah, so one of the things I kind of already mentioned, excuse me, one of the things that I was mentioning earlier was that key component of training the entire care team, not just looking at it as this is a provider issue. Because when we all talk about things like unconscious bias, if we're honest, to some degree, every person has challenges with that. And it's going to take us looking at it from a holistic perspective and making sure that we're getting the right information for the sake of the right considerations to the entire care team. For all we know, it could be a social worker that failed to report something to a provider, and that's why the provider never considered a specific thing when having a conversation with the patient, or a miscommunication or gap between the provider in the clinic and the pharmacist. It's all about us working together, and that's why I really love, it's probably the public health practitioner in me too, but I really do love wraparound models, because it's like a network within a network where individuals are working together. But it really does make sure, by training the entire care team, making sure that everyone's getting consistent information. It's also too around, if there are care teams that have those patient navigators or certified peer specialists and things of that nature, that can make a significant difference too. Because as I was sharing earlier, sometimes when you look at a healthcare visit, like a provider visit, different people in that clinic are getting different information about the same patient. We used to talk about it all the time, where we're like, well, they told you that. Why didn't they tell me this? What did it, and so it's important to note that that is so key to ensure that individuals are getting the right information. Now, of course, having certain laws, legislation, and policy information to protect these audiences are key. And that's some of the work that's been done historically. We hope that that will rise again shortly. But in the big scheme of things, it's all about us as individuals and our collective networks and audiences doing our part, like every day.
Yeah. So have you, in the populations that you work with, have you found that the disadvantaged populations use the websites, portals, or apps of the health plans, PBMs, or specialty pharmacies?
So my personal experience is no, they don't. My personal experience is no, they don't. You have a very select few that do. Typically, certain audiences, just in general, being overwhelmed with their circumstances, right? Living with certain chronic illnesses, or, I live with a chronic illness myself. It's not a rare disease, but you're living with certain chronic illnesses or rare diseases or chronic diagnosis, and you're just overwhelmed by circumstances. Even if everything is quote unquote going well, right? You're often people might look at things from a perspective of like, oh, that's homework. They're like, can you help me with this? So while they're grateful for the resource, they really do appreciate services like a patient navigator or a social worker or a community health worker that can help them navigate these portals and gain access to them more. So, but in terms of how many of those individuals, based on my experiences, are accessing those on their own quite a bit, they're not accessing it probably as much as they could, but with the support of certain care teams or certain, community advocates and things of that nature, I think people will utilize them more. Sometimes it honestly is just a lack of awareness. I don't know that particular portal access is available to me and I don't know what it's for. And so it's another aspect or component of more education. You know, with education, we know it's always like rinse and repeat, but particularly when people are in hard situations where they live in chronic pain or have chronic, situations in their health, they are present, but they're not present. And so they may be there, but find themselves dissociating while they're having a conversation with you because they're worried about the pain in their leg or in their body. And so that's something to just consider. I know we have to document in their charts like, hey, we educated them on this, right, in the notes. But considering that education component may need to happen several times over and over before we're sure, or we may have an outreach representative follow up with them to see if they need some additional support or assistance with it after a particular visit.
The follow-up to that question is, if they're not using the portals, as you suggested, are mobile phones a good method of communicating with these patients?
Hey, I can't answer for everyone, but I also have a background where I worked for managed care organizations for about 7 years. And with that, we actually gave, one of the programs I worked for, we gave patients free mobile phones as a way to access and eliminate excuses for accessing your healthcare. And we still saw challenges in compliance, even with giving them a free phone. Well, I will say is that was 10 plus years ago, and mobile phones are more readily available now to like everyone. Well, it provides a sense of let's access things quicker. Everyone's attention span is on 9 seconds, thanks to infinite scroll. And so I do think that mobile phones, based on even my conversations with patients recently, it's about how can I get this done and how can I get it done quickly? It was just about quick access for them. Let me get the information to them as quickly as possible. Whereas sometimes, though we know we can access email, for example, on a mobile device as well, individuals might take time to access it quicker if it's readily available to them on their phone and maybe through like an app or something of that nature versus just being through their email or things of that nature. So yeah, it is improving for sure, but the advancements in technology means that there are other apps and things available that are competing for our interest. And so that's something that we just have to, we move along with the times, but we also just have to ask certain audiences, what are you using to, because some people might be like, hey, we just have our own distinguished standalone app, but do we need to do more on social media? Because that's where the audiences are. So that's a question to consider.
Yeah. For both of you, Richard, Jocelyn, thinking about the people in our audience and our typical PQA audience that want to contribute to advancing equity in rare disease care, what are some practical ways you think our members could get involved?
Richard, I'll let you start with that one.
Oh, that's a tough question. Well, look, I mean, our audience is a professional audience, and I think, I think one of the issues is, often the underrepresented communities just aren't at the table as we're thinking about ways to improve access, care, and addressing those unique needs that they have, which were really kind of revealed in the survey. And those needs vary based on the subpopulation type, right? So the barriers that Hispanics are facing are not the same as LGBTQ, they're not the same as African American. So I think, if you're working in the rare disease space, just being constantly mindful of, are we accounting for the needs and perspectives of diverse audiences in our work? That's where I would start.
No, I think Richard highlighted a crucial point. Like it's so key to just have those conversations to make sure that we are normalizing having conversations with the patient and caregiver population. It could be the smallest of things, but making sure that the right people are at the table is so imperative. That's so much of what we do at RDDC and BWHI. It's so crucial to us to ensure that we should not be having a conversation about a particular thing and not have those individuals in some degree represented. Because otherwise, you're speaking for someone when that individual's voice needs to be centered and elevated. That will never go away. We will always have audiences that are left out or less than, and it's going to be key for us as healthcare professionals to, I always use the term, you've heard me say it several times during this call, always consider. Because even if the person looks like you, sounds like you, is from the same place as you, it is two different outcomes. It always will be two different outcomes. And so that's how we amplify a patient or a caregiver's voice. We do so by making sure that we're normalizing those conversations, and we're also normalizing the awareness associated with it.
That makes sense. Thank you very much, both of you. We appreciate the time that you've gotten to spend with us and all the knowledge and the data and the surveys. I mean, it's all really been nice to see up on a screen. So thank you. We're going to wrap up with some announcements from me. You should be able to see our slides here. Oops. So the 2025 PQA annual meeting is coming up May 19, 20, and 21. We're going to Florida, Tampa to be exact. And the annual meeting will be featuring a variety of networking opportunities, as well as over 50 speakers who will share their insights on topics such as value-based care, Medicare Part D, obesity therapeutics and care, medication therapy management. So many good topics. Registration is open for the 2025 annual meeting, so please sign up, and Rachel has dropped that link in the chat if you'd like to click on it. Additionally, if you have any questions about the annual meeting, we have a specific email address, meetings@PQA. We'll drop that email address in the chat as well. Additionally, before the annual meeting starts, PQA will host the pre-meeting session, the Medication Use Quality Live CE event on Monday, May 19th at 8 a.m. Come join me. The session's target audience is those who are new to quality, as well as students, and those who have some familiarity or stakeholders in the medication use quality landscape, but would like to deepen their knowledge. It will be 4 hours of live CE credit. And that link is also in the chat. Last, next month will be our stakeholder advisory meeting, Wednesday, March 12th at 1 p.m. Registration information is available to PQA members. It will be in the member resources library, or just keep an eye on your email for updates as they will be coming very soon. Oh, thank you. There's the stakeholder information. Take a screenshot of this or keep an eye out in your email. To all of our participants, thank you so much for joining our call today. Have a great day.